Yes, sir. We are good to go.
Okay. So, good evening, everyone. This is our continued educational series, the Gastro Liver Academy Discussion Forum. Glad. So, we have completed already 6 topics, very important for the primary care physicians who are practicing, who are interested to do practice in the field of gastroenterology and liver disease. This GLAD initiative is with our mentorship of Professor Subrat Acharya, Professor Y.K. Chawla, who is also editing the our board, and with this successfully, we have conducted sessions on very important and common topics, and we request you to be attentive throughout. We'll request questions from you in chat box, and also at the same time, we'll request your honest suggestions how we can improve also. So with this, because Professor Acharya has busy for a personal commitment, we are going to start the session. And today's session is very important topic. In fact, as a gastroenterology or hepatology practice, nearly half of the patients comes with this problem, that is functional dyspepsia. And to highlight on this, and there is approach how to manage, will get lighting presentation from Dr. P.D. Goswami, and sir is an expert in this field and is very renowned in this. And after that, we'll go for the discussion. So over to Professor Goswami. Sir, please.
Thank you, Dr. Chaudhuri. Uh, Good evening to everyone. As Dr. Chaudhuri has mentioned about this issue about functional dyspepsia, is a major issue, and all of us as a practitioner, whether specialist or otherwise, we have to face this problem every day, every time. I have put this topic as functional dyspepsia. Is there a light at the end of the tunnel? Because for long years, we are knowing something about the dyspepsia or functional dyspepsia, and there is no end to it because the uh, ignorance about the exact pathophysiology, and also we did not have the exact picture how to manage this problem. But for last few years, there are a lot of developments are coming up, and that's why there is a hope about the management proper in this problem. So what is our practical problem, what we see in our practice? This is what, so anytime you will see somebody is coming to you, I have a headache, I have high blood pressure, and at the same breath, the patient will tell you that it is due to gas. Complain as well as the cause they explain themselves. I have loose motion and it is due to gas. I have bad sleep and again it is due to gas. I have pain abdomen, again it is due to gas. I have nausea, vomiting, and again it is due to gas. I have got a losing weight for last few months or few years, but problem is the gas. Probably except for pregnancy, for any problem, any symptom, and any complaints, any person, it is the gas. So that is the problem we have to face. And what is this gas is all about? This is the dyspepsia. The cis and peptine is a Greek word and it means the bad digestion. That is what the gas the patient used to talk about. It is a persistent or recurrent pain or discomfort centered around or in the upper part of the abdomen. That's what we or patient used to describe. The dyspepsia may be functional one, it may be structural one, or it may be not related with the GI problem at all. three things may happen. Uh, but it is a concern for the patient point of view. The major factor why they used to complain or used to come to a doctor, it is the problem they fear, the serious potential fatal condition. It may be thinking about the heart disease or cancer of the anywhere in the body or GI cancer. All these are the priorities or thinking about or anxieties, you can say, from the point of the patients. The functional dyspepsia, uh, functional dyspepsia, if you see here, just a minute, it refers to the condition in patient who lack an identifiable structural or biochemical cause for their symptoms based on a routine clinical diagnostic workup. There is no structural cause, but there is dyspepsia. That's what is functional dyspepsia. It is 10 to 30% prevalence all over the world. It causes reduced quality of life, concern with the emotional distress, again, economic burden. It is a heavy one. And all over the world, we have got this problem of functional dyspepsia. According to the Rome 4 criteria, who actually work about the functional disorders of the GI tract, they have described by definition, newer definition in 2016, it must include one of the or more of the following, like bothersome postprandial fullness, or it may be early satiation, or it may be epigastric pain, or it may be epigastric burning. And all these must be related not with any structural disease. And again, the criteria fulfilled for the last 3 months with symptom onset at least 6 months prior to the diagnosis of it. The complexity of the problem, cause, and the effect is very difficult to establish. We don't know. There are so many things we should consider. The symptoms experienced are intermittent and are changing. No specific findings in all the patients present. Symptoms and the findings do not actually correlate. There is no universal effective treatment. The response to the treatment is difficult to predict, and also there is high placebo response rate. That is the problem with the functional dyspepsia. Then we have got the symptom complex, starting from the bloating, pain, fullness, heartburn, early satiety, belching, nausea, vomiting. So everything can happen from the patient's point of view and functional dyspepsia. Then again, we have got another issue is functional dyspepsia versus the uninvestigated dyspepsia. Anybody coming to you with the problem or description of the dyspepsia does not mean that it is a functional dyspepsia. We have to investigate it, and after that only we can find it out. Because this study clearly shows that in different studies, from carcinoma of the stomach, from peptic ulcer, from GERD, we have got the dyspepsia. And after that, of course, we have got the functional dyspepsia where there is no any structural disease. So again, if you see the functional dyspepsia among all the patients presenting with dyspepsia, maybe around 50 to 60% of the patients. This is another study again showing functional dyspepsia up to 60% of the cases. Otherwise, in GERD, 30%, 13%, peptic ulcer, 25%, malignancy, 2%, and so on. Different studies will show the different pictures. This is another study showing again with the high number of patients with dyspepsia, cancer, peptic ulcer, GERD, and without any structural disease or functional dyspepsia in 55% of the cases. We have got another issue about the dyspepsia. It may not be related to the GI tract, because it is related with some of the medications. I am showing whole line of the medications, and with this medication also the patient may have the symptoms of the dyspepsia. Uh, According to the Rome 4 criteria, the functional dyspepsia may be in two types: postprandial distress syndrome or epigastric pain syndrome. Postprandial distress syndrome, or PDS, what we call, again may be early satiation or maybe postprandial heaviness or fullness. Epigastric pain syndrome may be the epigastric pain or epigastric burning. In the first part, it may be at least bothersome 3 days a week. On the other hand, it may be bothersome at least 1 day a week. That's what the definition about the Rome 4 criteria. Then again, there may be overlap of these two problems, postprandial distress syndrome or epigastric pain syndrome in 31.8% of the cases. There may be overlap of the symptoms. Then functional dyspepsia itself may be overlap with other conditions. Already I have mentioned the different causes of GERD, gastroparesis, or IBS, and different symptoms I have shown here in this particular slide. So that's why again it is very difficult sometimes to give the correct diagnosis because of this overlap. Then coming to the pathophysiology, what pathophysiology we have got today? Definitely it is a complex problem, it is a multifactorial, and also it is not completely elucidated because so many things have to come up in future. The pathophysiology, again, it is centered around the delayed gastric time or emptying, CNS dysfunction, H. pylori infection, hypersensitivity of the GI tract, mainly the upper part, impaired the accommodation of the stomach. Yes, there are so many risk factors like female sex and increasing age of the patient, socioeconomic status, H. pylori infection, NSAID use, low education level, and renting accommodation. And given again the studies show that being married is also a risk factor for the dyspepsia. So again, the pathophysiology remains unknown. It should be clear to all of us. It is not clear till today. Other points are there. For example, gastric emptying time, almost 25 to 40% cases we can see it. Almost 40% cases, there is a problem with the fundic accommodation. The upper GI motor and sensory dysfunction. There is altered visceral sensitivities, hypersensitivity to mechanical distension. 20 to 60% cases, it may associated with the H. pylori infection. There is increased sensitivity to the acid environment with the impaired duodenal acid clearance. Of course, there is issue of the psychological distress and post-infection dyspepsia. H. pylori infection, it is today established that considered a possible cause of the functional dyspepsia syndrome. And 20 to 40% cases of functional dyspepsia, they have got the H. pylori infection. The delayed gastric emptying, again, here you can see a major pathophysiological mechanism where you can get the functional dyspepsia. It is also found in case of 20 to 50% cases of functional dyspepsia have got delayed gastric emptying, and most patients likely to report mainly in this group for postprandial fullness, nausea, and vomiting. But the correlation with the functional dyspepsia symptom still not settled one. The impaired gastric accommodation, again, it is an issue in almost 40% patients of functional dyspepsia. We are not going in details about it. Fundal accommodation. Normally, what happens whenever we take food, the fundus actually relaxes and it can accommodate the whole food in that particular region. But in case of the functional dyspepsia, those patients, it is seen that the impairment of the accommodation in the fundus cannot relax properly, and that's why also patient present with the functional dyspepsia or postprandial distress syndrome. Then also concern is about the hypersensitivity to the gastric distension. The enhanced sensitivity is seen to the stomach distension or gastric distension, and that ultimately results in the functional dyspepsia. And again, this is the duodenal hypersensitivity is a newer factor coming up. Earlier, we did not know much about it, but today it is established that hypersensitivity to the mechanical stimuli of the stomach and upper part of the small bowel is frequent in case of functional dyspepsia patients. They have got also hypersensitivity to the chemical stimuli like acid and lipids, mainly from the stomach. And here lies the duodenal inflammation, there is mucosal permeability, and food antigens. So, duodenal eosinophilia has been reported extensively nowadays in functional dyspepsia patients, and it is also related to the early satiety. The infection, stress, acid exposure, smoking, food allergy, all are implicated in the pathogenesis of duodenal mucosal accommodation, inflammation, and also there is changes in the permeability of the mucosa of the duodenum. And that's how, again, there is environmental exposure. Like the acute infection, after that one, the GI tract, the patient may have the symptoms of dyspepsia in 10 to 20% of the cases. That's what we call the post-infection dyspepsia. And of course, it is a short-lived one, but sometimes it may prolong for a long time. The features of the infective agents and the genetic predisposition is also a matter of an issue. Then again, it is established there that the psychological factor where we can get more and more patients with the dyspepsia. The physical as well as the emotional abuse in the adulthood and the difficulty in coping up in life events that may be involved with functional dyspepsia. The bidirectional relationship problem exists between the gut and the psyche. So at the end, if we see the whole factors, here is the list. The H. pylori in functional dyspepsia patient, we can get it in 20 to 40% of the cases. Delayed gastric emptying up to 30% of the patients with functional dyspepsia. Impaired accommodation up to 40% cases. Visceral hypersensitivity 50% of the cases. Of course, none of the above we can get in 30 to 40% of the cases. And at the end, the psychological factor is very high in functional dyspepsia. Over the past decade, there has been a dramatic change in the how the whole issue is conceptualized. Earlier, we thought that this is mainly the brain gut motility disorder, when the gut pathology was the major issue without any gut pathology. Mainly it is the brain gut motility disorder. It was conceptualized like that. But today it is a different issue altogether. It is a gut driven disorder. It is an observable GI pathology. Earlier we did not got anything problematic inside the GI tract, but today it is the GI pathology is coming up, and that's why I was talking about the duodenal pathology, mainly the inflammation, the change permeability of the mucosa, and also the changes microbiome in the duodenum that ultimately leads to the functional dyspepsia. That's what the most exciting and the new information is duodenal inflammation, what just now I have mentioned about, mainly the eosinophilia. There is increased mucosal permeability. There is duodenal microbiota is disturbed. One, impaired enteric nervous system, reflexes, and also evidence of the systemic alterations like increased levels of the circulating cytokines, small intestinal T cells, and whole issue is shifted the interest from the stomach to the upper small intestine. That's the changing scenario in functional dyspepsia. So how should we evaluate these patients with the functional dyspepsia? So this diagnosis usually with by exclusion. Interview and the examination objectives should be very rational and very clear one. So initiate a symptom-based diagnosis, address the patient's concern and the expectation what they have. Explore the psychological issues, the pattern of the illness, of the behavior of the patient. It should be given of prime interest and importance so that the patient can understand that you are listening him properly. A suspected functional dyspepsia, whom to investigate? Not all the
It's
patient we
9
should
o'clock.
investigate with all the issues. We should always think of the age of the patient. If it is over 50 years, with new onset of the symptoms, we should investigate. If it is a failed therapy, symptomatically you tried, but it is failed, you go for investigations. If the patient has got any cancer fear, or if there is a history in the family cancer, you go for investigations. And of course, the patient concern is of most important one. Then for the evaluation, the diagnostic workup in the patients with the dyspepsia can be time consuming or costly if it is undirected one. That's why we should be very careful about it. And these are the issues we can go for with endoscopy, radiography, then we have the ultrasound, 24 hours, pH metry of the esophagus, lactose intolerance, gastric emptying testing, urea breath test or hydrogen breath test. We should do all these things, but again, we should be very careful what I have already mentioned. Where it is needed, you go for it. There's a big question about scope or not to scope. Yes, we should remember the patient needs a doctor, not an endoscopist. So again, there is a rational approach for the endoscopy. You consider the factors for endoscopy, age of the patient, and background prevalence of the serious illness of the patient or the family. Then also you see the alarm symptoms of the patients. Here, the alarm symptoms should be carefully sorted out. If there is the weight loss, bleeding, dysphagia, recurrent vomiting, above 45 years of age, with new onset of the symptoms, anemia, occult blood in stool, or unresponsive dyspepsia, you have to go for the investigations with even the endoscopy. Here you can see one patient who were presenting with the dyspepsia, but you can see the esophagus. Here you have got the linear ulcerations of the lower part of the uh, esophagus. Then this is again another patient of mine who presented with the symptom of dyspepsia, but on endoscopy you can see the enteral ulcer and came out to be the growth of the stomach. Another patient presenting with dyspepsia, but he has got the ulcer in the pre-pyloric area. This is another very interesting case. Young girl came to us and presenting with dyspepsia and also vomiting. But on endoscopy, we found this is the picture. You can see the whole stomach is full of the roundworms. And if you go further, you can see up to duodenum, there is only and only the roundworms in the. So this is the thing. That's why it is important always to check, uh, investigate whenever it is necessary. You can see here. So ultimately, that's why there another study I am showing here. In the treatment of dyspepsia, we can go for empiric treatment and also after endoscopy. This study clearly showed that the endoscopy arm, there is more satisfaction, lower healthcare cost, and also the improved quality of life. So sometimes for satisfaction of the patient also, you may have to go for the endoscopy so that the patient is very much assured that he does or she does not have any structural or big issue about it. Coming to the management of the functional dyspepsia, what we should do, it can be frustrating because the poor understanding of the mechanism of the symptoms, there is heterogeneity of the causes, that is the problem, and also there is lack of highly effective medical treatment. The general management principle always you should give stress to the benign nature of the dyspepsia. You have to explain them. Reassurance, weight reduction, stop smoking, avoid high fatty meal, avoid specific food that precipitate the symptoms, and also eat frequent or small meals. However, there have not been any study clearly or systematically which have given a proof answer to these ones, but this may be beneficial to the patient. Regarding the H. pylori, if it is present, definitely we should go for the treatment because ultimately it has got the pathogenic importance in peptic ulcer, but there is a limited role or direct association in functional dyspepsia with H. pylori because 40% cases of maximum it may be present in functional dyspepsia cases. But whenever we have got positive H. pylori, it is better to treat and eliminate the H. pylori. The treatment approach, the other things what we have got the antacids, it is commonly used by the patients, but RCT trials have failed to show any benefit over the placebo. Then we have got the acid inhibitions like H receptor antagonists or PPI. It is regarded as the effective treatment. Control trials, they have shown gain of only 10 to 15% and the ineffective in case of postprandial distress syndrome, mainly the PPIs. There is prokinetic, and that prokinetic again we have got, sorry, uh, use of it again Asian consensus is the first line of treatment in postprandial distress syndrome. American College of Gastroenterology and American Gastroenterology Association guideline also we should use it. Any the types of subtypes of the dyspepsia we can use it. At Rome 4 guideline they have shown that the first line treatment in functional dyspepsia in postprandial distress syndrome. Uh, Treatment approach again the prokinetic agents whole a lot of the list we have got up to the ecosiamide. When ecosiamide came to the market, it was initially thought that it will be a wonder drug for dyspepsia, but ultimately it may not be so much of a successful story altogether, but it can be used in some percent of the cases because ultimately these prokinetic agents they are helpful in those patients where there is a problem with the accommodation of the fundus. So that's why we can use it in this group of patients. It exerts a significant benefits over the placebo. Unphysiologically, it accelerates the gastric emptying time, and also it improves the postprandial fullness and the early satiety. Then we have got the antidepressant drugs like tricyclic antidepressants or SSRI. Also, we have got the antispasmodic if it is associated with some sort of pain even, and anticholinergic also may be helpful one. Then this is the algorithm for the treatment of the functional dyspepsia. You, if it is positive, eradication of H. pylori is important one. After that, you classify postprandial distress syndrome or EPS or post epigastric pain syndrome, and accordingly you use the acid suppressing agents or prokinetic agents, and that's how you go on for the treatment. And those patients who are refractory, ultimately you should go for the psychological therapy as well the experimental therapy, because nowadays there are some issues coming up or informations coming up regarding use of some herbal medicines from different parts of the world. uh, in 2013 there was a very interesting editorial in the Nature reviews, the glimmers of the hope of functional dyspepsia. The patients with functional dyspepsia can look forward for a brighter future. Why? Because so much of information are coming up. That's why the next question was, is there a light at the end of the tunnel? Yes, the new treatment options we have got today is the anti-inflammatory drugs like Montelukast in pediatric functional dyspepsia patients, non-absorbable antibiotic like rifaximin in case of your functional dyspepsia. Low-dose tricyclic antidepressants are also helpful for functional dyspepsia, and specific probiotics in different studies have shown some ray of hope. It is a very exciting time in this field of the research as the new answers seem at hand for this particular problem. I had the chance to listen to a lecture in one of the meeting of the DDW a few years back, and this he is one of the authority on the functional dyspepsia. So what he suggested, what we should do as a doctor, what to do in in dealing with the patient with functional dyspepsia, make a confident diagnosis. What to say, you just talk to them that it is a problem of the nerve disorders of the bowel. Nerves are overly sensitive to the physiological events. So that's why you have got this problem. Don't say that we don't know anything about it. Like what not to say to the patient. We don't know what you have got it. We don't know what causing your pain. This probably is a functional dyspepsia, and here is the door. You please leave it. It is not like that. This is the teaching what we should go for. Better you go for the reassurance to the patient. You always talk to them politely, sensitively, listen to them, and ultimately try to assure them. That's why my line has been the reassurance should be more than just this is functional dyspepsia. Then this is my last slide about the hello Mr. Joshi. So this long time back, almost 12, 15 years back, I had a patient called Mr. Joshi. He was around 35 years, came to my clinic with whole lot of papers with him. He was describing his problem, and immediately I got to know from all the investigation he has gone through, is a case of functional dyspepsia. I told him, I explained him everything. But after 2 3 days, when I was in the medical college, early morning around 9 o'clock, just I will start my endoscopy clinic or sometimes in the OPD clinic. This person will give me a call and he will again start telling the same thing. I have got pain, I have got distress, I have got gas and all. So one day, second day, third day, fourth day, continuously at around 9 o'clock, I will get his phone. So what I did, after 4 days, I decided it is better for my side to call him. I called him exactly at 9 o'clock. So hello, Mr. Joshi, how are you today? So after 2 3 days, this gentleman became so nice. He came to me and he was surprised to get a call from the doctor. He was so happy and he is a good friend of mine till today. His problem is over after that. That is the my message, that always we should be very much careful, very much sensitive to these patients with functional dyspepsia. With this, I conclude my talk. It affects the 25% of the adult population of the world and whom they ask for medical attention. The pathophysiological mechanism that are believed to be important in symptoms development are impaired postprandial gastric accommodation, delayed gastric emptying, visceral hypersensitivity. The role of the H. pylori in the pathogenesis of functional dyspepsia is still controversial. Acid inhibitory agents and the prokinetics are the mainstay in the management of the functional dyspepsia. And of course, the psychological therapies may be helpful in appropriately motivated patients. Thank you for your kind attention. Thank you.
Thank you, Dr. Goswami.
Hello.
Yeah, Dr. Goswami, am I audible?
Yeah, I can hear you now. Yeah. Hello.
Oh, sorry. Okay, so network is unstable. Yeah, sir.
Yeah.
So basically, we gone through some functional dyspepsia. So what you told in brief. So can you sir summarize when, because people fear two things. One is whether they will be cured of this disease, and frequently they have
So
no
I,
pain because
I
they have
cannot hear
endoscopy.
properly.
So, sir, what is your take on this for the physicians to reassure the patient that it can be cured? How they can guide them?
Yeah, this is very important one. My message to all my uh, listener delegates today, that this is not cured completely. You cannot cure functional dyspepsia. And we should be very much realistic about it. And we should be clear to tell the patients also that they should not expect complete cure of the problem. So they should be told that yes, you have got the problem, is a problem with your nerves in the intestine. It is not a big issue. This is not a structural problem. Uh, Only point is it will take some time to adjust with it, and you will be ultimately free of those symptoms. Not it is curable, it will be completely okay. It is not possible. But if we are very much assuring them that there is no structural disease, nothing to fear, then probably it will be very much helpful to them.
Thank you, sir. So we got a lot of questions in the chat box. So there is a significant. This is by Dr. Ajay Gupta. He wants to know there is a significant overlap between functional dyspepsia and gastroparesis. So how you differentiate them?
Yeah, it is. It is a difficult issue. That's why I have mentioned in my slide also there's gastroparesis, or it is a functional dyspepsia, it is very much difficult one. But the point is, if you have the facilities, before that probably symptomatically we should check it whether it is a postprandial dyspepsia or a distress syndrome or it is epigastric pain syndrome, or if you have got the facilities for the electrogastrogram, we can check it. Then again, the scintigram, that can also ultimately give the diagnosis. But the before that, before going to all these investigations and all, I think the symptomatic, ultimately symptomatically you have to treat the patient, and you have to go for it with the symptomatic treatment. If it is not responding one, then only you should go for the further studies of this population of the patients with functional dyspepsia or gastroparesis.
So there is another question also from Dr. Ajay Gupta. What is the role of confocal endomicroscopy?
Uh, I don't think that we should go to that type of even investigations for functional dyspepsia. In only very selective few people, patients may require that type of investigation. Otherwise, I don't think anything. What is your take? Uh,
I think, sir, it is one of the limited availability.
yeah,
First of all, second, implication for routine practice will be difficult. This may be a open say area whether there is some problems which we are maybe missing. Like in colonoscopy, there is a collagenous colitis or a microcephalitis which is often not diagnosed unless you go for a random and biopsy. So this may help. And Dr. Ajay Gupta has pointed that in confocal endomicroscopy there is increased epithelial gaps in the duodenum and reduced transepithelial electric resistance that are inversely related to symptom severity. Okay, this is I think I'm not aware of, but if it is there and I think it opens some window for some therapy, and I think it is area of research rather than we can say it is a routine practice. And
yeah.
if
In fact,
anyone is
the duodenal pathology is coming up in a big way for the pathogenesis of functional dyspepsia today. There is the increased permeability. There is some gaps in the epithelial region, mucosal layer of the duodenum. Ultimately, that's how there is inflammatory process going on inside the duodenal wall. And also the role of the microbiome, changing microbiome inside the duodenum as well as the proximal part of the small bowel, ultimately leads to some damage of the mucosa of the duodenum. Maybe in this category of patients, probably it may be confocal endoscopy may be helpful one.
thank you, sir. And then next is from Dr. Moniz. She wants to know is there any correlation between functional dyspepsia and constipation?
Anything?
Constipation and functional dyspepsia.
Uh, the
Constipation. Hmm.
relation. Yeah, it is. Sometimes it may be overlap syndrome. Already, I am but definition is a completely different issue altogether because Rome criteria also the functional dyspepsia means in the postprandial distress syndrome. After the food, you have got the fullness of the abdomen, early satiety, or after food, you may have got the epigastric burning or epigastric pain. That's what, by definition, that's what the functional dyspepsia. And constipation is a completely different issue. But at the same time, we should remember the patients with IBS, whether it is a constipation predominant or your diarrhea predominant, there may be some overlap of the symptoms. But by definition, it is a completely different issues altogether.
Thank you. I am also the same opinion. Then another question has come. Should you suggest to go for gastric emptying study routinely?
I don't think so. Regularly, we should go for testing the gastric emptying time because, first of all, symptomatically we can give the treatment. If suppose the patient is not responding, then only you can go for these investigations along. But before that, you do the other test as well. For example, what I have shown, that you have to be sure about the absence of any structural diseases. You do the endoscopy, and other what I have mentioned, the radiography also may be helpful one. And after that, probably there is a role after that about the gastric emptying time testing.
Yes.
What do you think about?
And there is question is on about the diet plan for a patient with AFD. Any special dietary recommendations from your side, Dr. Goswami?
Yeah, there is actually, in fact, there is no specific diet for functional dyspepsia. In fact, till today. But the point is, first of all the patients, they think that yes, doctors should advise their diet in functional dyspepsia. That is the reason we should be clear to them that which particular diet is causing you trouble, symptomatic, you should avoid that one. That is my simple take. All the patients I always advise like that. But again, the low FODMAP diet, what we describe in case of your IBS, again they are showing results the same way in case of functional dyspepsia. Otherwise, you take whatever you like it, whatever is not giving any trouble to you. That's my message always.
Thank you. So we have discussed the most important part today, the dyspepsia. I think we have covered last time, and we have now covered functional dyspepsia. So there are two common things we come across. First of all, as a general care physician, as a primary practitioners, dyspepsia has to be taken with few red flag signs, as rightly highlighted by Dr. Goswami. And also, our previous video recordings are available in YouTube. From that also again through. Last time we have discussed a very simple way of approach to a patient who comes with GID symptoms or the dyspepsia. Today we discuss when you ruled out major causes or refractory, non-responding to medications or the functional dyspepsia. So it's a composite parameters, clinical evaluation, proper history taking, dietary interventions, lifestyle measures, and few workups. So all these combined will give a clue for this management. So with this, I think Dr. Goswami, if you permit, we can close the session.
Yeah.
Already it's going to be 1 hour. So we are going next session at the same time on the 4th Friday, 8:30 p.m. in month of November. And next time will be the also very interesting topic on gallstones, which is a very common topic of interest for physicians as well as for the public. With this, we will close the session today. Thank you.
Thank you, sir. Thank you.